Hi everyone, we're back and we're so fortunate to have Dr. Marie Claude Beaulieu from the University of Sherbrooke with us here today in the studio here at the 2019 Canadian Rheumatology Association and Arthritis Health Professionals Association annual scientific meeting. May I call you Marie Claude?
Yeah, for sure.
Bien. Marie Claude is a family physician and working at the University of Sherbrooke, and specifically in ways to make family practice, I think, better integrated if from a multidisciplinary perspective. And certainly that's kind of what I call the modern approach to treating patients like me. But most importantly, Marie Claude, identifying patients like me, which has always been a challenge at the family practice level, because you're not necessarily the ones that follow us in our journey. You're there, but our primary treating physician is a rheumatologist. So I'd like to hear from you about your work at the University of Sherbrooke, and tell us what you think is happening now and what you think state-of-the-art is in family practice, and how, given the theme of this meeting, how that builds a bridge to better care for inflammatory arthritis patients.
Okay.
Yeah.
So I'm in the community practice base since 34 years, and
just a rookie, hey?
Eh?
Just a rookie, we say en français, in English. Rookie, a bébé.
Okay.
It's a joke. All right, I'll stop trying to make jokes.
Okay.
That's a long time.
Yeah, it's a long time, And it's very important for me, as we are in community base, we are working with other clinicians that are can be physiotherapists, occupational therapists, nurses, and so we are working in team and with nurses also.
Yeah.
And we have the change, because as we are a little community, even if it's a big university, we know the specialists, and we can have a good communication with rheumatologists.
Okay.
But I think, for sure, as you said, it's very important to have the early diagnosis.
Right.
So family physician has to be aware of the disease, so they have we have to have information about it. And also, one point that I think is very important is that it's not always like in the book.
Yeah.
Sometimes patient can present
In very different ways.
Yes, and they can have the disease, but the markers or the CRP or other things are negative, and often the family physician is not sure, and so it's important to that we can ask the specialist to see patients rapidly, and that we both like bridges, that we have a good communication anytime with them. Right.
You know, it's interesting you say this about a sort of not strange presentations, but individual presentations of patients. We're all snowflakes, every one of us. And patients out, you know, kind of on the street, a lot of us go away and don't seek treatment, or maybe aren't really going to be proactive with treatments or exercise or some of the things we know help people at an early stage. Yeah. They don't do it because their rheumatoid factor test was negative. So they say, I can't have it. So it's really important, I think, for family practice to be able to explain to a patient who's presenting with inflammatory arthritis symptoms that those tests are just, they're like little assistants.
Yeah. But it's not the diagnosis.
Yeah.
If you don't have that's it. It's so important to have a good history and a clinical examination. So we have to be good also to detect synovitis, but we have also to, I think, to trust the patient. The patient know himself. So we have to trust the patient, and if it's something different, and even if the tests are negative, you have to go further.
You have to keep investigating.
Yeah.
So we hear a lot. We're Canada's largest patient organization. We have 50,000 members across the country. I cannot tell you, Marie Claude, how often we hear patients express frustration over not being heard, that they know something's wrong. And a lot of times those patients get kind of written off or dismissed as, some sort of malingering or catastrophizing or things like that, how can patients at the family practice level, how can we better tell you early on some of these things? Like, for example, my family physician, I still have her, she's the one who literally diagnosed me. I presented very classically. I had a very swollen finger. I had very swollen knees, but initially a pain in the ball of my foot, which very common presentation. She saw that and she said, I think you have arthritis, sent me away to test. I had a really high rheumatoid factor score, really high. Back in the day, they used to do the ESR sedimentation rate. Now CRP is a more sensitive measure for inflammation. But she took the time to explain those things to me and why those were clues. How do you think family practice can improve that? Like, is it because you have a good relationship with a network of rheumatologists, but they're overtaxed? Like,
but yes, and it's important and we have formation, and even I have the chance to be in a teaching clinic. So we have resident in family practice that are coming, and even people in the MD school. So you have to always be aware, and we heard a lot more and more about this. So we know that it's important, and even in meetings and scientific meetings, CME, it's very important. So even what we did, I worked with a rheumatologist, and we create some workshop. And we went into different clinics, family practice clinics, with patients. To help the clinician to know what's happening.
It's like showing them exactly what's happening.
And it was helpful. We did a little research project about that. And the family physician told us that it was very helpful to have this. So this was at the Sherbrooke level, but we tried to in Quebec, I don't know the rest of Canada, but in Quebec, we tried in the 4 university to try to put family physician aware of these things early.
So then you think, how do we, en anglais we say scale up? How do you make that model work across the country, or at least across Quebec?
We made knowledge translation. Translation. So we had some articles and papers, not articles, papers. And we have also a presentation that we did to other family medicine group. And even in the rheumatology community, the rheumatologist in charge of that project told about in conference other even it was presented at the CRA a few years ago, and so it scales up a little,
almost by word of mouth. When you're a family physician and you've been practicing a long time, you've also been doing research and teaching at that length of time as well, I imagine. What do you think are the big, where has family practice, with relation to arthritis, or specifically inflammatory arthritis, what do you think have been your biggest steps forward in terms of care for patients?
I think the more and more is because everybody are very, very busy. So the more and more important is to try to keep in touch with people, with collaborators. I really, for me, it's very important, collaboration, interprofessional collaboration work. So I think this is important. And also, we are trying with our government to if it's possible, to give access to patients rapidly to occupational therapists or physiotherapists, even if it's only one session, but just to give them some cues at the first beginning of the disease. It can be so helpful.
Boy, you know what, Marie Claude, I'm so happy to hear you say that, because I'm involved, I have to give a talk actually in a couple of weeks in Vancouver. To nurses and allied health professionals, people like that. OTs, PTs.
OT.
Occupational.
OT is occupational. And PT is physiotherapy.
Right. And the people that I'm part of this presentation with, they asked me, well, what would you think would be kind of the most important thing for inflammatory arthritis patients once they were first diagnosed? I said, well, occupational therapists and physiotherapists, if I could have access to those people right away, they're fonts of knowledge. They have huge knowledge banks, and they can teach me very practical skills to help me overcome some of the challenges that you really initially face early on before your other treatments start to work. If I had that, but when I was 30 years ago diagnosed, Marie Claude, I was on a wait list. It took me 6 months to see a physiotherapist. And I think, how would that have changed my life that first year? And I'm telling you, it would have made a massive difference to me. It would have certainly prevented some of the disability that I have today. And I'm not crying, you know, sour grapes or whatever. But I'm just saying, these are, I think you're definitely on the right track. Like saying to government, okay, seeing a rheumatologist is one thing, but there are some critical other members of the team
that you have to see early to prevent, like you said, even if we know that medication works well, actually.
But it still takes time, and they still take time. Sometimes 6, 12 weeks, you know, 4 or 5 months before you get really good disease control, if in fact you can find a combination that works. So I'm thrilled to hear you say this. We're going to turn to the audience, Marie Claude, and ask if there are any questions. Anita?
Can you define what knowledge translation is, and what tips do you have to offer those who want to be successful with doing knowledge translation?
Okay, it's when you have like a good project that it's with good issues, it's important that you can let people benefit. Yeah, that's it. Sorry for my English.
No, it's all good. You're beautiful.
Benefit of that. So that what we call in our community knowledge translation is to help people to diffuse good things that we have.
That's good. You can get those diffusers in your home that make the air smell really pretty. We need to plug all those in around scientists and get. Yeah, it really, knowledge translation is sort of one of the final steps in an entire system change process or a research process.
And what was the other question? Was tips?
How to do it.
How to do it successfully.
How to do it? We are working in collaboration in Quebec with a university or a CME center. So if you have a good thing that worked well, you can said that it will be interesting to it can be at lunchtime webinars, it can be at during a meeting of people in the clinic. So what is better for the people, and you can
yeah, this is a really important point that you make, Marie Claude. To be successful, you have to know which audiences are going to be interested in the benefits that you want to get out, right? Knowledge about the benefits. And so how you do that with patients is very different than it is to fellow clinicians, where you do CMEs or lunch and learns or things like that. With politicians, you want to take your results to government, and this requires advocacy work. If you're talking about general public, well, then you want to look at sort of some mass strategies like social media, maybe getting some key reportage in newspapers. So knowledge translation, I guess, to be successful requires identification of audience and understanding the types of messages you give out that deliver these results and that will resonate in those different audiences. There's a whole science around knowledge translation implementation.
Because you have to adapt.
There's a science, exactly.
You have to adapt to your audience.
To audience, to time, to circumstance, to resources. Yeah, it's complicated. It's just not as easy as I'm shouting from the rooftops my results, right? It has to be a bit more scientific than that. Well, you've been absolutely delightful, Marie Claude. We're so happy you came in.
Thank you.
We understand as patients how important family physicians, family practice, and this multidisciplinary style of helping patients is the modern way. And then the building the bridge to the rheumatology community to fast track good quality care is so important. So we want to clone you, and we want to send you across Canada and make sure you get this done everywhere. So thank you so much for coming in.
Thank you very much.
Yeah.